Gives me great pleasure to introduce a friend and colleague, Tiberio Frisoli, from Medical Director at the Structural Heart Center at Henry Ford. We all know Tiberio. He's been one of the leaders in this space and always pushing the envelope. He regularly performs minimally invasive heart procedures and has pushed the envelope in many of the mitral and tricuspid, also aortic interventions. And he completed his training at Henry Ford and has chosen to stay there and to enrich both Detroit and the state in general and help the people of Michigan through collaboration with his mentors and peers. Tiberio covers many hospitals and is always available as a resource for people who have questions. And we are very lucky that he's able, in spite of having multiple obligations tonight, he's going to be able to talk to us for Transcaval access for TAVR, something that they pioneered at Henry Ford, and we're very excited. So without much further ado, Tiberio, it's on you now, my friend.
Thank you. Can you hear me, Stan?
Very well.
Okay, thanks so much. Thanks. What a pleasure. Thank you for that introduction. I'm speaking about a topic that's something I'm particularly interested in, and you know, you showed that data about the amount of alternate access that's done in Michigan at 96% femoral. I would estimate that at Henry Ford Hospital in Detroit, we're doing upwards of 10 to 15% alternate access, in part because of referrals precisely for that. And so there are patients out there that, as we all know on this call, that don't have great iliofemoral disease, as Mike said earlier. So I was blessed to have trained at Henry Ford in Structural Heart Disease Fellowship in 2017 when Adam Greenbaum presented the first live case of transcaval TAVR live to ACC, and I was the fellow that did the case with him and Rob Letterman and the NIH group, and I didn't realize at the time what a moment it was, and that was the birth of percutaneous electrosurgery. And so this is a topic I really enjoy talking about. I hope this is not a competition of alternate access. I know Raed's speaking next about carotid access for TAVR. I happen to be a huge fan of carotid access for TAVR, but I'm going to speak about transcaval access for TAVR. So let's see here. I have no disclosures. So why is this even feasible? Back in 2011, 2012, Adam and Rob Letterman and the group that pioneered this, they looked at swine models, and they did percutaneous cavo-aortic work, and they found that the swines were not dying from retroperitoneal hemorrhage, and the reason is that the retroperitoneal space, the aorta and the IVC in this portion of the abdomen are retroperitoneal. The retroperitoneal space is at a higher pressure than the inferior vena cava space, and so if one were to create a hole in the IVC and in the aorta, the blood would flow as a fistula from the aorta to the IVC rather than pooling in the retroperitoneum. Hence the birth of this transcaval concept. So I'm going to start here with a case. This is a 87-year-old female. I performed a transcaval TAVR on her two weeks ago, and you can see by CT scan that her iliofemorals, they're straight, they're not very tortuous. The calcium's mostly in the common iliac, but I think we'd all agree that the vessels are fairly small. It'd be interesting to see how many on this call would perhaps attempt this femoral and then perhaps deal with a perforation or a dissection on the back end. But we at least would have a low threshold for going alternate access. And in this case, we chose transcaval access. This is how we plan a transcaval TAVR. The same CT, the gated CT that's done for TAVR planning, is all you need for planning the transcaval access portion of the procedure. Access is usually, or I should say, crossing from the IVC to the aorta is usually between lumbar L2 and L4 spaces. And the CT here will show you on this axial cut, for example, where there's a calcium-free area. It'll also show you whether there's any intervening bowel or not. On the top right picture, you can see the bowel anterior to the IVC and the aorta, and that bowel is not between the IVC and the aorta. On the bottom left image, you can see at the transcaval crossing point that there's a relatively large calcium-free area in the side of the aorta, and then the bottom right is the angle between the IVC and the aorta. In this case, as is most often the case, the IVC is to the right and behind the aorta. And in this patient, it's 17 degrees. So you'd go RAO 17 and to obtain a side-to-side projection, and then you go orthogonal to that, 90 degrees LAO to that. So in this patient, it would be LAO 73 degrees to get an image where the IVC and the aorta are superimposed, and I'll show why that's important in a second. Also very important on the CT pre-procedure planning is the aorta itself in terms of its dimensions. So on the top left is the aorta at the L3 crossing point for this patient, 11 by 13. And then the top right is 3 centimeters above that crossing point. The bottom left is 3 centimeters below the crossing point. This is important so that one can plan in a rare but worst case scenario. If you have a bleeding complication, you know what your bailout equipment needs to be. So in this case, I would use a balloon that's roughly 16 or so millimeters to tamponade an aortotomy bleed, and I would have a covered stent that's about self-expanding covered stent that's about 16 millimeters available. The bottom right two images show the distance from that aortotomy crossing point to the renal arteries and to the aortoiliac bifurcation, 48 and 32 in this patient. That so that you know what your size is, so you don't have an endo leak if you place a cover stent, and also so that you know what your landing zone is. Ideally, you should have about 10 to 15 millimeters distance from the renals and from the aortoiliac bifurcation. And so this is what a transcaval TAVR may look like fluoroscopically. The very first thing I do after obtaining access is I do a cine fluoroscopy, and I sweep from RAO to LAO, and I'm looking for calcium. Now, I already know on the CT scan where my calcium-free crossing point is, but I like to confirm it on cine fluoroscopy. And it may not project perfectly here, but I have a snare, a gooseneck snare in the aorta, and you can actually see the calcium train tracks in the aorta, and you're looking for that calcium-free zone. I also do an aortotomy, an aortogram and a venogram, and I'm looking mainly for branches. We know that by CT scan, but I'm giving myself kind of a lay of the land of how the IVC and the aorta look relative to each other and where the major side branches are. And then in that bottom right image, which is an important one, remember that in this patient, the RAO 17 was the image I was going to use for crossing. The orthogonal view, LAO 73, is where I can see the aorta and the IVC superimposed. And my catheter, my donor catheter, which is a renal length RDC or IM catheter with the wire and the microcatheter, I'll get to that in a second. I want to see that they're pointing right down the barrel of the snare, of the gooseneck snare, and in this case, they are. So that's how I plan the procedure. And now, as I'm ready to cross, I electrocauterize a wire. And what you're going to see in the bottom left there is something that's not uncommon, which is that the wire did not get through the aorta on the first attempt. The enemy of electrosurgery is calcium. And that wire hit probably some eggshell calcium, didn't make it through the aorta, made it through the IVC and the retroperineum, but not through the aorta. And so some micro movements are necessary, perhaps moving just a millimeter caudal or a millimeter cephalad. And you can see that now on the second attempt, the wire made it through. Now, I don't know if you noticed, but right as the wire is going through, the patient moves. Maybe it doesn't project well. It can be painful for the patient. A lot of nerve endings in that aorta, so we tend to pre-treat just prior to closure with a narcotic, morphine, Dilaudid. Now, on the bottom right, you're going to see, so the wire is through. We snare the wire with the gooseneck snare, and we're able to advance a 035 microcatheter. So the wire, the Astata wire in this case, is through an 014 to 035 converter, whether that be a piggyback or I use a 2x20 Cook balloon. And then over that, you're able to advance an 035 microcatheter, and then through that, a very stiff wire. I use a Lunderquist. What you'll see in the bottom right, in the right side image, is the sheath, the E-sheath, in this case, going over a Lunderquist wire. And you'll notice that right as it's about to go through the aorta, right there, there's a little bit of a herky-jerky movement. That's not uncommon. The aorta tends to be pretty calcified in these patients. So at that point, it's a standard TAVR. In fact, the positions of the operators is identical to a transfemoral arterial TAVR, and that's one of the advantages of a transcaval TAVR, is that the muscle memory is that of a transfemoral TAVR. The positions are the same. Now, on the back end, and this is a very, very important part of the procedure, is percutaneously closing the aortotomy that you created with your E-sheath. So this is a Amplatzer ADO, a ductal occluder plug through an Agilis steerable catheter. The E-sheath has to be pulled all the way back from the aorta to the IVC. If there's one way to really cause a hemorrhage in a patient for whom you've done transcaval procedures, it's if you occlude the venotomy while leaving the aortotomy open. So if you pull the E-sheath back across the aortotomy, but you haven't pulled it back across the venotomy, the blood is going to go into the retroperitoneum. But if you pull it all the way back into the IVC or the femoral vein, you've allowed for that fistulous flow, path of least resistance from the aorta to the IVC. And what you're seeing there is passive exposure of an ADO plug. The hemostasis occurs with the waist of the plug, not so much with the disc of the plug. You can use a pigtail from the femoral arterial axis or from the upper extremity arterial axis to do some puffs and see some landmarks. This wire that you see from the vein to the artery, that's an 014 coronary wire, in this case a BMW wire. That's like a safety wire. In the event that you mistakenly pull the plug through the aortotomy, you still have a lifeline from the vein back into the aorta to get across with a microcatheter and get ready to reposition your plug and finish the job. The right image is an aortogram showing what we call a type 0 closure. There's no fistulous flow whatsoever. There's no flow out of the aorta. That's a nice result. These are the type of final closures you can get and how we define them. On the left is again a type 0. No, actually that is not a type 0 closure. Sorry, that's mislabeled. A type 0 closure would be no fistulous flow whatsoever. A type 1 closure would be that there is fistulous flow, and then a type 2 closure would be that there's some extravasation into the retroperitoneum. So if you see a mushroom cloud or some blood that's above or below your Amplatzer device, that's not clearly in the aorta, not clearly in the IVC, that's when you're getting your balloon or your covered stent ready. It's not common, but it does happen. And so the key here is being prepared for a possible retroperitoneal hemorrhage, having a bailout balloon and a bailout covered stent, dimensions of which you already know based on the pre-procedure CT scan, to be prepared to close. So again, the concept of why this even works is because the retroperitoneal pressure is higher than the IVC pressure. And on the right side here, you will see the equipment that's needed to do this. You'll see the 014 guide wire is in an 014 to 035 wire converter, which is inside an 035 microcatheter. So in this case, this was the original equipment that Adam and Rob and others used, which was an Astado inside of a piggyback inside of a Navicross. I use a Astado inside of a 2x20 Cook over-the-wire balloon inside of a 035 CXI. Why? Because I'm doing a lot of these in really calcified aortas. The navicross won't always glide across easily, and having that balloon allows you to minimally dilate the aortotomy just enough to get the microcatheter across. Once the microcatheter is across, you get a stiff wire, again, usually a Lunderquist. The back of the Estado wire is connected to an electrosurgery pen, a Bovie, and clamped with a hemostat. And I usually cut at about 50 or 70 watts. And this, by the way, on the bottom is a link to a online video that I created that shows an in vivo live step-by-step transcable case. This was the original data back in 2011, 2012. Adam and the team went down to the NIH and they did this in swines. And I just want to draw your attention to the fact that of the original 14 pig models that were done, 4 aortotomy were intentionally left open, and the pigs survived, and a week later that aortotomy was closed, illustrating that this concept of fistulous flow from the aorta to the IVC rather than full out extravasation and hemorrhagic shock is in fact what happens in vivo. What is the data? I'll draw your attention just to this one study. There's more data forthcoming. I believe Adam and Keith Allen have an analysis of TVT registry data comparing transcaval to other accesses for TAVR. This was a study that we did at Henry Ford some years ago in patients that were not transfemoral feasible. And what you'll see is in this Kaplan-Meier curve on the bottom right, the bottom curve, the survival is the y-axis. The dotted line is transcaval, and the red line is transcarotid, and the top dotted line is standard transfemoral. And there was no statistically significant difference in 1-year survival. In other words, the survival was comparable. Now, what I'll draw your attention to is that the baseline characteristics, the demographics of these patients are quite different. So I've circled in red that the transcaval patients, as compared to the transfemoral patients, had a much higher STS, 8 versus 6. They had a significantly higher rate of COPD, 40% versus 27%, more cerebrovascular disease, 43 versus 21, and a higher rate of peripheral vascular disease, 76 versus 23. Not unexpected. There's a reason that these patients were being treated with transcaval access. And so we're not truly comparing apples to apples when we compare transcaval TAVR patients to transfemoral TAVR patients. They are more comorbid and they have higher risk. And despite that, we did not see a significant difference in 1-year survival. There's some other data. There's a 2022 paper from Rob Letterman is the first author from JACC Interventions comparing transcaval to transfemoral and percutaneous axillary and TAVR. And there was transcaval TAVR compared quite favorably, especially to percutaneous axillary TAVR, lower stroke rates, lower mortality rates. So this is an 85-year-old female, and I'm gonna show that it's not always rosy. Things can happen. This was a patient with severe peripheral artery disease, and what you can see here is again standard procedure, repetition, just so that you guys pick up on the procedural aspects here. Cine fluoroscopy, sweeping, identifying the calcium in the aorta, advancing an electrocauterized wire from the IVC. Now there's my balloon. There's a 2O balloon across the aorta so that we could advance a sheath. And what you see here is that despite that, the sheath doesn't go. You can see the E sheath getting hung up on the calcium of the aorta. And so at this point, we performed some more dilatations, gentle dilatations in the aorta, and we're ultimately able to get the E-sheath across from the IVC into the aorta, as you'll see there. And again, at that point, it's a standard transfemoral TAVR. Now, here's the closure, and what you'll notice here is that the blood, the dye is not just going into the IVC. There's some extravasation. You almost see a mushroom cloud there. And that's when you're acting quickly to get your balloon and or covered stent ready. This was a bailout with a balloon and a covered stent. And this is not a common occurrence. We are not usually needing to do this, but I want to illustrate an example of a worst case scenario of what can happen. Why did this happen? Maybe because the aorta was particularly calcified. You saw the difficulty with advancing the E-sheath. I did this case back about 4 or 5 years ago, and I called Adam a day or two afterwards to run the whole case by him. And he said that every once in a blue moon, there's a patient whose physiology in terms of that differential pressure of the retroperitoneum to the IVC is just not ideal. But we were able to salvage this case with a balloon and a covered stent. So if you're prepared and experienced in these procedures, even when you do have a retroperitoneal hemorrhage, that can be bailed out. Let's see here if this will move on to the next. Okay, so bear with me here. Okay, so just 20 seconds to say that once you or your center becomes experienced with transcaval TAVR, one of the advantages is that the whole transcaval axis has far-reaching applications. This is an example that Dr. Ollinger and I published of an endovascular repair of a thoracic aortic aneurysm using transcaval aortic access. This patient had no other options. This is a report that my colleagues at Henry Ford and I published on LAVA, ECMO, left atrial veno-arterial extracorporeal membrane oxygenation with transcaval access. So you have your drainage sheath and your reinfusion sheath all venous, no large bore arterial access for patients with cardiogenic shock, for example. This was a review of transcaval access for large bore devices, and this was a paper we wrote on transcaval access for 5.0 impellas for cardiogenic shock. And I just draw your attention there on the right side that of these 43 patients, less than 20% of them had pre-procedure CTs. And the transcaval access was successful 100%. So even without the knowledge of where that calcium-free zone was, or if there was any intervening bowel, we were successful in performing transcaval access to facilitate placement of mechanical circulatory support for cardiogenic shock patients. This is just 20 seconds, an example. Another application of transcaval access. This was a lady who had multiple strokes with pretty ugly looking atheromas in the aortic arch. And my interventional neurology colleagues called me and said, is there anything you can do to suck this out? And the AngioVac system requires a 22 French sheath. Her arterial access was way too small for that. So what I did is I got a CT, I planned transcaval access, and this is all images I've shown you before, again, repetition, so that you can see what we do here, but a cine fluoroscopy sweep, a AP projection, a orthogonal projection, an electrocauterized wire from the IVC to the aorta, microcatheter, stiff wire, and now you have large bore access to the aorta from a femoral vein. And because of that, we were able to advance the 22 French sheath that is required for the AngioVac system. Trying to move to the next page. There you can see the AngioVac system being advanced. I'm using sensory embolic protection to prevent stroke, and their closure with, again, that ductal occluder And in this case, I ballooned it, and in the end got a type 0 closure. And I can show you the final result if this will move to the next image. Let's see. I am trying to advance. Let's see if it will go. Maybe, okay. And so this is the pre, as I showed you earlier, and this is the post, and there was basically no atheroma left. So in conclusion, why I like Transcaval, the muscle memory, it's identical to transfemoral in terms of positions. You're closing a vein, not an artery. It's not uncommon to have poor carotid or axillary access in patients with poor femoral access. The data suggests the outcomes are pretty good in a very high-risk cohort of patients. And once you and your center become experienced with Transcaval, there are broad applications that go beyond TAVR to help our patients. Thank you very much for the opportunity.